In epidemiology, one of the most important questions is whether an exposure is associated with a health outcome. To answer questions like this, we use measures of association such as the risk ratio and the odds ratio. Today, we're analyzing real surveillance data from the Behavioral Risk Factor Surveillance System, commonly known as BRFSS. This is one of the largest ongoing public health surveys in the world. It collects health data from hundreds of thousands of US adults each year, making it a powerful tool for understanding chronic disease patterns. Our research question is simple but important. Is obesity associated with diabetes? We begin by loading our cleaned dataset. The dataset contains two binary variables: obesity, whether a person has a BMI of 30 or higher, and diabetes, whether a person reports being diagnosed with diabetes. By cleaning the dataset beforehand, we ensure that 1 always means yes and 0 always means no. This makes our epidemiologic calculations straightforward and transparent. Next, we create a 2x2 contingency table. This allows us to compare disease frequency between groups. In public health research, this is often the first step in studying associations. Here we're looking at a classic 2x2 contingency table built from our dataset. This table divides adults into two groups, not obese and obese, and then shows whether they have no diabetes or if they do have diabetes. Let's walk through what these numbers tell us. Among adults who are not obese, 238,730 do not have diabetes, while 28,833 do have diabetes. Among adults who are obese, 101,695 do not have diabetes, but 31,312 do have diabetes. Even though the non-obese group is larger overall, the number of diabetes cases in the obese group is noticeably high relative to its size. Before doing any calculations, we can already see a pattern. Diabetes appears more common among individuals with obesity. And this is exactly why contingency tables are so important in public health. They allow us to detect patterns in population health data quickly and clearly. We then calculate risk, which simply means what proportion of people in each group have diabetes. For obese individuals, risk equals number with diabetes divided by total obese individuals. For non-obese individuals, risk equals number with diabetes divided by total non-obese individuals. This tells us how common diabetes is in each group. Risk is intuitive and easy to interpret, which makes it very useful in public health communication. The risk among obese adults is 0.235. That means about 23.5% of adults with obesity have diabetes. Now compare that to the risk among non-obese adults, 0.108. So about 10.8% of adults without obesity have diabetes. From a public health perspective, this is a meaningful difference. Even before calculating ratios, we can clearly see that obesity is associated with a higher burden of diabetes in this population. Next, we calculate the risk ratio. The risk ratio answers the question: how many times more likely is diabetes among obese individuals compared to non-obese individuals? If RR equals 1, this means there is no association. RR greater than 1 implies higher risk in obese individuals, and RR less than 1 signifies a protective effect. This measure is especially useful for public health messaging because it directly compares probabilities. The result is risk ratio equals 2.18. What does that mean? It means that adults with obesity are about 2.18 times as likely to have diabetes compared to adults who are not obese. In simpler terms, diabetes is a little more than twice as common among people with obesity. Finally, we calculate the odds ratio. Instead of probabilities, odds compare number with disease divided by number without disease. The odds ratio is commonly used in logistic regression and case control studies. The result we have here is odds ratio equals 2.55. What does this mean? It means that the odds of having diabetes among adults with obesity are about 2.5 times the odds among adults without obesity. In other words, obesity is strongly associated with diabetes in this population. You may notice that the odds ratio, 2.55, is slightly higher than the risk ratio we calculated earlier, which was about 2.18. That's expected. When a condition is relatively common, like diabetes in this data set, the odds ratio tends to be larger than the risk ratio. By performing these calculations, we are quantifying the association between obesity and diabetes at the population level. Risk ratio is easier to interpret and preferred when working with cohort-style data. Odds ratio is commonly used in logistic regression and case control studies. Because our dataset is cross-sectional, we can calculate both, but we interpret them as associations, not causation. We cannot say obesity causes diabetes from this analysis. We can only say there is a strong association. Longitudinal data would be required to establish temporal sequence. This analysis suggests diabetes is more than twice as common among adults with obesity. Obesity appears strongly associated with diabetes at the population level. From a public health perspective, this supports obesity prevention programs, community-level nutrition interventions, physical activity promotion, and early diabetes screening in high BMI populations. This is how surveillance data translates into policy and prevention strategies. In the next video, we will extend this concept into a more advanced modeling framework by learning multiple linear regression, where we can examine the effect of several variables simultaneously. Continue the series to build advanced real-world analytical skills for public health using R.